Hello, everyone, and welcome to the latest webinar from Zoe, which is all about living with long COVID. And today I'm joined by Dr. Claire Steeves, who's a reader in aging research and a clinician, and Professor Alexander Hammers, who works in imaging and neuroscience before his COVID work, and is also a sufferer of long COVID. And both my colleagues are from King's College London, where I also work. I'm Tim Spector. I'm a lead scientist of the Zoe COVID study and professor of epidemiology here at King's. So thanks to everyone who's submitted their questions. We're looking forward to getting some answers and discussing in depth the topic of long COVID. With high rates of COVID at the moment, low deaths and hospitalizations, our concerns are really shifting from since the majority of us are now fully vaccinated. And with over 900 cases a day of long COVID, we estimate from the Zoe app coming to light, we really need to start talking about this seriously and tackling these issues as a serious long-term health problem. So in this webinar, we're going to be talking about who's getting long COVID, what it's like to live with it, what are the implications, and the advice going forward, and taking a lot of your questions on this subject and what we've really learned in the last 18 months. Let's get on to discussing what is long COVID, because the definition has actually changed quite a lot. So Claire, do you want to start this off?
Yes, certainly, Tim. It's very timely that we're having this discussion because yesterday the WHO, the World Health Organization, produced their new definition of long COVID, which they call post-COVID-19 condition. And really, that's quite similar in definition to what NICE, the National Institute of Clinical Excellence in the UK, brought out last year, which was that post-COVID condition or long COVID is a condition that comes after infection with SARS-CoV-2 virus, which lasts maybe 3 months after the onset of COVID-19 or more. It can come and go. So the definition doesn't mean you have to have it for the whole of the 3 months, but it can come and go at least for 2 months. And it's not explained by an alternative diagnosis. So people need to have had some kind of a review to make sure that something else doesn't explain their symptoms.
Right, it's a bit complicated. So do you have to have had it for like 2 months or 3 months? It's a bit unclear to me. Although the WHO often do modeled, slightly complex definitions.
I think basically what they're saying is that that generally people who are defined as having this condition are having it for longer than 3 months from the time that they first got infection. But we know that many people who are living with long COVID don't have their symptoms all the time. Sometimes they come, sometimes they go. And so that's why WHO wanted to sort of bring that into the definition. So I think what it's meaning is that it accepts that symptoms may fluctuate or relapse over time.
Right. Okay. And do you think this definition is helpful, Alexander?
I certainly do. It's the first reason why it's super helpful is because it exists. As many of us remember, in the beginning, the sheer existence of long COVID was debated, and a lot of sufferers felt that they weren't being taken seriously. It was put down to anxiety, depression, whatever. And I think that's an experience that many post-viral syndrome sufferers have had. So an official definition by the World Health Organization is certainly useful, even though I agree with you, Tim, that the 3 month, 2 month business is a little bit complicated. Probably it was derived via something called a Delphi process, where they essentially asked over 200 people to give their input, and maybe that's a slightly muddled definition is what you get when you ask 200 people, but it's extremely useful to have it. And they also insist on the link to SARS-CoV-2 infection, but also admit that when there hasn't been testing, that it should be probable rather than confirmed necessarily. So I think it's very useful to have it.
Yeah. As a sufferer, what would you like it to be called? What do you call it yourself?
Well, long COVID, because that's it's long. It's got something to do with COVID, and why call it post-COVID if we don't really know the physiological mechanisms behind it? And long COVID is a nice and catchy name. It has caught on. I really I think it's a good term. And Claire, you're smiling because in the Nature Medicine paper you did with Carol Sudro, you also called it long COVID. I see no difficulties with the term.
Okay, so it's a bit of a clash between the sort of epidemiologists and the actual patients and clinicians, I think, on this one. So, okay, well, it's interesting to get your take on it as a patient. Claire, how many people get it? What's the best estimate of the real prevalence?
Well, I think different studies have produced different figures here. And I think the key things to sort of bear in mind when you're looking at any of the prevalence figures is, has the study really understood whether or not this is explainable by another condition? And so have they made sure that, that alternative diagnoses have been at least excluded to some degree? And also, so have they taken account of other causes for symptoms? And also, symptoms differ by different age groups, and we can see that very clearly in the longitudinal population studies that we've looked at. And I think ONS recently produced a report which showed some numbers, still very large numbers of people in the UK and abroad who are affected by this. It's probably between 3 and 12% of people who are affected by coronavirus who go on to have symptoms for longer than 12 weeks after initial infection. And if you consider people who are not affected, in their daily life, so they can still carry on normal life, there are significantly more people that are affected by symptoms that are ongoing after the virus. So I think there are large numbers, but obviously there are smaller sets of people who really are living with a condition which is affecting their everyday life, and they cannot carry on in the same way. And it's those people and those numbers that we really need to focus our attention on, because those people need to get back to daily life.
And have we got an idea how many are still suffering at a year yet?
Well, there definitely are individuals that are still suffering at a year. There are people that I've seen in clinic who've been affected by coronavirus in the first wave, certainly in the second wave. Most people that I've seen that have been affected right the way from the first wave are really getting better now. So I think that's good. And actually, most of the people I'm seeing are from the second wave. The percentages are really difficult to assess, actually, and across all the longitudinal studies, there's really great uncertainty about the precise numbers that are experiencing it for more than a year.
So, I mean, we've got quite a few questions on this, and certainly I get on my Twitter feed. People, particularly who are affected in that first wave that didn't have access to PCR testing, feel that they're not being counted, and therefore the prevalence of long COVID has been underestimated. And we sort of ignore those people that have now had it for 18 months. Do you think there's anything in that?
Well, certainly I do. And I think that it's really important that both the NICE definition and the WHO definition really make this stipulation that you don't need to have a proven test positive in order to receive a diagnosis, and also to get rehabilitation support and medical investigation for your symptoms. It's really important that we don't disregard the fact that people who might not have access to testing, or may not have tested at the right time, or indeed never even got an antibody response, or that antibody response waned, and so their tests appear negative, those people shouldn't be excluded from getting care. And that's definitely written into all these definitions.
Yeah.
I do think though, Tim, that there's a significant under recognition within the healthcare codes that certain groups probably are not getting access to that diagnosis. And we can see that from looking at electronic health records, the sort of risk factors, as it were, that play out in electronic health records being slightly different from longitudinal studies. For example, showing that if you are living in a higher sort of socioeconomic area, you're more likely to get a long COVID code. Of course, we know that it's likely that in reality that it's the other way around, that you might be more likely to be at risk of long COVID if you come from an environment with lower socioeconomic status. So we can see that definitely that's affecting how many people are getting the diagnosis.
Okay, well, important to bear that in mind. Alexander, as someone who's got it, can you say what are the risk factors? What are the main risks for getting it that we know now that we didn't know maybe at the beginning?
Well, of course, the COVID Zoe study has played a major role there in defining the risk factors, which seem to be higher age, female gender, and the number of symptoms you have in the first week. So if you've got more than 5 different ones, that's bad. And a high body mass index, so basically being overweight. So those seem to be risk factors. And as Claire hinted, of course, there is a lot of interwoven things where your team have also shown, Tim, that diet plays a role in how badly you get COVID. I don't think we know specifically whether that affects long COVID, but there are some risk factors, but they definitely don't explain everything. And what I found particularly baffling is that it seems so unpredictable. So, there's a couple of professors on Twitter who were marathon runners before and then got it very badly. And I also know 75-plus-year-olds who were super unfit before, got a sniffle for 5 days and never talked about it again. So it's Russian roulette. It's completely unpredictable.
Yeah. And does the menopause have an effect on that?
I'm not sure. Claire, do you know?
I'm not sure either. I think that again, the differences between men and women could be biological, but they also could be about symptom reporting, Tim. We see that women in many different health conditions are more likely to recognize and to seek help for a condition that they suffer from. Or
underreporting in males rather than...
It might be underreporting in males. And I certainly would echo Alexander's comment that, that there are marathon runners who are young men who have gotten long COVID. These risk factors are there. We can see them in data, but ultimately, long COVID is something that affects people of every socioeconomic background, every social group, males, females, etc. We look for these risk factors to try and get an understanding of whether we can see any biology or cause behind it and follow that up those signals. But ultimately, none of these signals are really very big.
Yeah. Okay. Well, the next question is about autoimmune disease, briefly, really, which we haven't had time to touch on a lot, but it is related to this male-female question because most autoimmune disease is in females. And I think Eve asks, is long COVID an autoimmune disease? What's the data for that? I think I can answer this as my previous life as a rheumatologist used to see lots of lupus and other nasty autoimmune diseases, which we thought looked similar in some ways to COVID, but we're not seeing anything on this. And there was a paper quite recently for a French group in the dermatology journal looking at these skin rashes associated with long-term COVID. And they did see autoimmune changes that basically sending out immune responses to tissues in the vessels and this was causing these rashes like COVID toes and things, but it doesn't look like other autoimmune disease. So it doesn't get vasculitis, which some people will know. So it does seem to be milder. So I think the question is, it's still rather open. It's not, doesn't look like other autoimmune diseases, but clearly the attacking of the body in the muscles and the skin is obviously an autoimmune phenomenon. And I think that's all we currently know at the moment. But it's not acting exactly like a sort of classical autoimmune disease, I think is the best way to deal with that. Okay, we're going to move on, and we want to discuss now what are the symptoms and treatments, and what are people's personal experiences. And everyone experiences illness in different ways, and this is certainly no different in long COVID to other diseases and conditions. So we want to hear about some personal testimonies, really. And we're going to start with our own in-house one. And I want to ask Alexander really about your personal experience, about, what was it like for you before and after, talk us through a bit about it, and also troubles getting a diagnosis and getting treatment.
Okay, yeah, thanks. The resident patient in the team. So I got it on the 26th of October 2020, and the sheer fact that I remember the date is shows you how important the date that was. So that was the time when the older kids in school were all getting infected, and we think we got it like that. And so my wife and I were wondering why we suddenly had backaches and then other joint aches, which at the time were definitely not a recognized symptom. So we didn't think about it at first. And only after 5 days, when teenager one said, "Oh, that's funny, I can't smell the food," we were all getting tested. And then 3 of us had it. And of course, the teenager recovered quickly, and my wife and I didn't. So in the beginning, it was a bit like the flu, multi-system symptoms and unable to get out of bed, but we've all had the flu, and you expect to recover after, say, 4 or 5 days. I don't think I've ever been longer than 3 days in bed with the flu, and this was different. So after a week or so, it was clear this was different, and this was not going away. My memory of the first 3 weeks is actually quite hazy because, I was unable to get up for any length of time. Of course, with difficulties at work, I tried to go back after 2 or 3 weeks, and then realized I can do 1 meeting and I need to go back to bed. It was absolutely steamrollered. And this is despite having been ridiculously fit before, not a marathon runner, but 10,000 steps a day, walking up to the 9th floor on a regular basis, racing bike, playing badminton in mixed groups with teenagers and so on. So very, very active for age. And, being middle-aged was my only risk factor, hence my earlier comment on the Russian roulette. And perhaps one of the most important messages from this webinar is don't get it in the first place, because if you haven't had COVID, you can't get long COVID. Then when things really didn't go away and I was unable to work properly after 4 weeks or so, I called the GP. Remember, so we're now in November 2020, no access to GPs. You couldn't get an in-person appointment at all. So he's very good. He took it seriously, and I don't think that has been everybody's experience. He also said, well, look, you've been getting X% better over 3 or 4 weeks. Expect this to last another 3 or 4 weeks. And I don't think I had wanted to realize that before. So that was helpful. Of course, we were logging with COVID Zoe. That was also very helpful, because I then started writing down my symptoms. I've brought an example. And so just logging them, because COVID Zoe is binary. Yeah, you've got it or you don't. And then you don't really see the progress. So what helped me is writing it down and saying, today I feel X out of 10 fit, or I've got a 5 out of 10 shortness of breath, because it did get better but you couldn't look day by day. You couldn't look even week by week. You had to look month by month. And then you saw the trend. And I would recommend this to other sufferers. Take a very long-term view and focus on things that get better. Claire, you already hinted at the data from COVID Zoe and other places. Things do tend to get better over time. And, you know, at some stage, I now have a reasonable quality of life. I would say I still have it, in particular, the fatigue and the tinnitus that's ringing in the ears. But I'm a neurologist, so I do what's best done with tinnitus, that's to say, ignore it. In the beginning, it was so loud, it was hindering quiet conversation, but now it's just in the background. And things like the chest pain and the heart racing, and in particular the post exercise symptom exacerbation, PSE. So you think you can walk again for 10 minutes or 15 minutes, and then you do it and you come back and you feel absolutely rotten for 2 days. Another difficulty, and I think that's a common experience, is so you don't have one symptom. You know, you hurt your knee hurts, that's fine. With long COVID, you've got the chest pain, the shortness of breath, this, that, and the other, the headaches, and they all come in cycles with different frequencies. And I found that very stressful because for months, you know, say you've got outpatients, you need to be fit, you need to be on your best form, but you can't predict how you would feel on the day because it's unpredictable. It will be some combination of different symptoms. Yeah, I've been talking for a long time. Let's get back to
no, it's very interesting. Did any treatments help you at all, or self-treatments help you?
Well, my GP is very good, but not as adventurous in terms of experiments as I am, as with my other hat on as a researcher. So he didn't feel comfortable prescribing me a trial of steroids, with this idea that you alluded to earlier, Tim, that maybe it's an overreaction of the immune system and then it should get better with steroids. But of course, steroids also have very serious side effects. So he wasn't keen on that, and I followed his advice. We tried a double-blind randomized controlled trial of cetirizine, an antihistamine, with one teenager randomizing the tablets, the other teenager putting them in yogurt, and my wife and I taking it without knowing what we were taking. But there wasn't a clear signal from that. But again, given that long COVID is very different in different people, you wouldn't expect the same treatment to work for everybody. And symptomatic treatments worked okay. So the German team has been trying to describe COVID headaches, which seem to be different from the usual tension headache, from migraines and so on. In my experience, they were bad, so I couldn't have worked through them, but they responded very well to small amounts of paracetamol or ibuprofen. And other than that, I've tended to use my body as a commodity for many decades, and long COVID has taught me to live with it and be gentle, especially with this post-exercise symptom exacerbation, and taking it easy. If you know you can do X minus 20% would be another important experience I would share with people.
And what about the vaccine? What happened when you took the vaccine?
I actually got my first vaccine on the 15th of January, again, a momentous date. And that was the first day, remember I got it in late October, the first day I was actually fit enough to travel into London. I live 50 minutes outside, and got the vaccine on the same day. There had been suspicions that the vaccine might help, and other people had said, well, maybe it will make it worse because you get the same immune reaction. I had equipoise, I didn't know, so I took it, and there was no dramatic effect, but around that time was when the chest pain stopped, and I think there has been 1 or 2 studies suggesting that there may be an effect. So definitely no bad effects. but also no clear immediate effect. What's very important to mention perhaps here, as putting my scientist and doctor hat back on, is that we now have very good evidence again from the COVID-ZOE study, that vaccination does reduce the risk of long COVID by about half. So it's definitely a good thing to have.
Yeah, no, very good point. Okay, well, I'm glad. So you've got better. You're not completely better, but you're definitely better than you were. We've got a clip here from a young person called Harry, who was unfortunately infected more than a year ago and is still unwell. So let's just hear from Harry now, if we can.
So I'm Harry. I'm 30 years old. Previously very fit and healthy, no previous medical conditions. I used to do a lot of outdoor sports, climbing, running, cycling. I got infected back in September last year. The initial infection was pretty mild, lasted about a week, just your typical flu-like symptoms. After the initial infection, I returned to work, assuming everything was fine, even though I didn't feel quite right. And then a few days later, I think 3 days later, almost like a switch flipped in my body. I started getting extreme fluctuations in my heart rate, chest pain, fatigue. I was bedbound for another month, and by the end of the month, I was unable to stand. If I stood up, my heart rate would go up to 160 beats per minute. It would also cause lightheadedness, chest pain, and a loss of balance. And actually, my symptoms became so severe that I went into A&E 3 separate times. And unfortunately, each time I was told that my symptoms were caused by anxiety. I've actually since had a cardiac MRI scan done privately, and it's shown that I do have myocarditis, so heart inflammation. So despite what the doctors were telling me, there was something quite serious going on. So my symptoms a year later, my fatigue has reduced significantly. I am able to walk, but I still have brain fog and heart issues.
Claire, would you like to comment on Harry's experience?
Well, actually, Harry's experience is a common story that I hear from patients, and also we hear reflected in social media, and many people have experienced this postural tachycardia syndrome. And it's interesting to hear that his MRI showed myocarditis, and indeed that can be detected as well on a blood test. Often a marker called CK is slightly raised in the blood, not massively raised, but slightly raised in individuals with myocarditis. So that can be a pointer for clinicians to really think about this. Also, the other problem with postural tachycardia syndrome is that you have to actually get somebody to stand up to be able to assess things. So things can look apparently normal if someone's assessed on a trolley in A&E. I wonder whether that happened. So it's really important that medical professionals are aware of this and also do a proper full assessment of an individual when they're presenting with these symptoms. Interestingly, there's been quite a lot of interest in whether or not some medications that are used in heart failure might be useful in this condition. And I think we'll be seeing trials information coming out quite soon about that. In the meantime, talk to your GP or your cardiologist if you can get through, because there are some potential treatments that are available for this.
I think just sad to hear about being labelled as just an anxious, neurotic patient. I think that's a lot of people did suffer that in the early days when there wasn't enough understanding of the condition, and that's probably one of the worst things, to feel rejected like that as a patient. Okay, I'm going to move on to the next patient we've got, which is a clip sent in from Zoe, who's a young person whose experience was somewhat different, but she is still suffering from the effects of COVID, and she tested positive in June this year. So let's just hear from her now.
Before I had COVID, I was really fit and active, so I was going to the gym 3 or 4 times a week, doing things like spin and quite high intensity exercise, weight classes, running, cycling, all kinds of different things. The initial symptoms that I had in the first couple of months, so that kind of July and August, I had really blurry vision. I was having chest pains and heart palpitations. I ended up in A&E because they thought I might be having a heart attack. And I would have these full body flares, a bit like a migraine, where my vision would go really, really blurry and I would have to sit in a dark room. Tinnitus as well, really bad tinnitus, like a siren all the time. And a really unpredictable set of symptoms. So to begin with, I couldn't really work out what was setting it off. It seemed to be doing anything. So having a phone conversation, watching TV, walking more than just to the end of the street would precipitate all these symptoms. So I really had to do nothing, like not speak to anyone on the phone, not watch TV, really, really reduce my activity level. Over the last couple of months, it's really improved. So I've got a lot better. I still am obviously not at work and not able to do any of the things that I used to be able to do, but I can now keep it under control by doing less than half an hour walking. So I can walk to the shop 10 minutes away and get a bag of shopping and come back again, and things like that. But I still have tinnitus. I still get chest pains and heart palpitations sometimes in the evening, but they're not as intense as they were. And I still get the sort of full migraine effect, but it's usually only between 5 and 7 in the evening. It lasts for much less time and it's much less painful, I guess. So yeah, my symptoms are easing off, but definitely still really restrictive in terms of what it is that I can do, really.
So obviously this tells us that there's more than one experience here. It's people do see it in lots of different ways. Got lots of questions here. Amanda asks, will I ever get better? She's obviously suffering herself. It's really complex to answer these, but I just wonder whether Claire, how would you, or Alexander, how you would start?
Well, I think we need to remain hopeful, and the overall experience has certainly been that the prevalence of symptoms and the number of symptoms does tend to go down with time. So I think it's very important to not give up hope and expect that things will become better. And also now that there are long COVID clinics, I do hope that there will be a lot of research coming out of those to help people with specific symptoms, like the tachycardia, and there are drugs for tachycardia. Will they help in tachycardia associated with long COVID? I don't think we know, but worth trying.
Okay, and so lots of questions have been coming in about recovery and what people are saying, well, naturally there is some recovery, but what can we do to actually speed that up and help it? From the health services. So Claire, what about long COVID treatment centres? Do you think they're helpful?
Yeah, I think they're really helpful, and there's several different sort of treatment centres that there are. I mean, there are long COVID recovery rehabilitation clinics, which include a range of professionals that can assess somebody and also think about how they can very gradually get people back to their goals. And I think that's the key thing that is really important here. And I think, Alexander, you kind of mentioned this, that one of the things that's really important is that people don't try too hard to get better too quick. I think an acceptance of the fact that actually the real lived experience is that most people do get better gradually over time. Whether things completely ever get back to normal for individuals is difficult to say. But the point is, can we find a way of living with those situations, making sure we don't exacerbate it by doing too much, or indeed by society not putting on too much pressure for people to get back to work, being accepting that this is something that takes time to get better, and we need to give that time, both as an individual and as a society. And I think the other thing is that people do need to get a proper assessment to make sure that there's not a specific problem that is interacting. And one thing I wanted to say, sort of coming on from Harry's clip, is we do know that there's an increased risk of cardiovascular events post-COVID. And it's possible that somebody might sort of be sitting thinking, oh, this is COVID, this is long COVID, but actually there's a different medical diagnosis that could actually be treated as well. And so I think that's why it's really important people do interact with their GPs. I know that it's difficult now and GPs are under a lot of stress, but the Royal College of GPs is very keen to get this right and very keen to refer people on. And I think the structure is definitely getting there, so people will be able to access the care they need.
Yeah, and it's important to tell people that GPs can refer anyone to these therapy clinics, and there's a website, your COVID recovery, and that's a way that everyone can work out what is available in their particular area. Although everyone tends to do, as up to now, has often done their own thing. So I'm quite interested to hear what happened to Harry about the treatments and some of them that have worked for him. So let's just listen to Harry again and see how he got on.
So regarding treatments, I've had next to nothing from my GP. I think this is the same experience for most people with long COVID, even the ones that managed to get onto a long COVID clinic. In general, I found doctors, if you can get them to take you seriously, they've been pretty reluctant to try medications. I appreciate that they have a do no harm policy, but at some point doing nothing, I think, is harm. And so people like myself included have turned to importing drugs from abroad and self-medicating. There are drugs out there that are helping people. Very safe drugs like H1, H2 antihistamines, which are over the counter in America, are helping some people with long COVID. Statins are helping others. Colchicine for people with chest pain. So there's absolutely options out there. And I think doctors need to be more forward thinking about how they treat and start being more patient-led than protocol-led, because there aren't any treatments that say long COVID on the packet. And for me personally, I've found that hyperbaric oxygen therapy has been incredibly helpful in reducing my brain fog, which kind of shows to me that I'm simply not getting enough oxygen to my organs, to my brain. And I think this really fits with the latest research that there is maybe like excess coagulation or microclotting in the blood of a lot of people with long COVID. And so maybe something like blood thinners or aspirin could help me. And I actually know a couple of people that are going out to Germany to get treated by HELP apheresis, which is a machine they've repurposed from filtering out cholesterol now to filtering out long COVID sufferers' blood.
Okay, so that was interesting. So Harry's experience really was that he thought that the clinic he attended, they were a bit too conservative of trying anything, and in other countries they might be a bit more gung-ho about trying sort of untested and anecdotal type treatments. And I think a lot of people are in that situation. Perhaps before we comment on this, let's see what happened to Zoe.
I've pursued a lot of alternative treatments. So I started doing an anti-inflammatory diet quite early on, so about 3 weeks in. I'm taking a range of supplements, so everything from C, B, D. I'm taking zinc. I was taking CoQ10 and a range of supplements that are supposed to help with inflammation. So it's called NAC and Seraptes and all these different kinds of things, all of which I found on the internet. There's a lot of forums and websites. There's a website called Stuff That Works, which has people's testimonials about the things that they've tried. Acupuncture is the only thing that I would say, in terms of a treatment that I've had, I've noticed a tangible difference after one session. I am getting quite a lot better, substantially better. And so I do think that all the things that I'm doing in terms of diet and exercise and lifestyle must have helped, because a lot of people don't recover as quickly. So I would definitely recommend that people look into how you can support your body in recovery through some of those diet and lifestyle things, as well as acupuncture.
Thank you to Harry and Zoe for those really interesting personal insights. And it's clear that obviously, and Alexander, I'm sure you realize this, that how important it is for people to feel that they're empowered to do things themselves rather than just being told there's nothing to do but wait. And I think that comes out really strongly from people. They do want to try things even if they don't know if they're going to work or not. I guess that seems to be part of the journey. And the one thing I would stress is that the one thing everyone can do is to look at their diets. We showed with the Zoe data that the quality of your diet, particularly as relates to your gut microbes, has a big effect on the severity of COVID you get. And we didn't prove it, but it's quite likely that also influenced long COVID. And so if that would be the first thing I would suggest in terms of a lifestyle change to do, even before you go to supplements and other things. Claire, are there any trials you can sign up to?
No, there definitely are. I think it's really passionate to hear those stories about people who are really wanting to find a solution and really proactively going after it. And I think that speaks to how much they need to find a solution. And there's this difficulty, isn't there, from a professional perspective, that we try to base our medical treatments on evidence base. And so we want to know whether or not a treatment is effective and whether or not it causes any harm. The good news is that there are quite a number of trials going on at the moment that are trying to look at specific medications. And some of them, as we've sort of like pointed out here, actually are ones which are used in everyday life, things like statins, things like aspirin. There are trials going on about that in the UK to see whether they help after COVID infection, especially after hospitalisation. And then other medications as well, antihistamines, other medications for specific sorts of long COVID as well. I think it'd be really good if the patient community put their energy into actually doing these evidence-based trials, because then we will find very clear sort of evidence that the effects that individuals might see are due to the medication. And really, there's no way of doing that other than a randomized blind clinical trial. And the reason why is because, of course, people do get better from COVID anyway. And so if an individual takes a medication or a vitamin and then sees an improvement, we don't know whether that's because of the medication or whether that's the natural progression in that person. Whereas when we do a randomized blind trial, we give, as Alexander sort of illustrated with his home randomized controlled trial, we give a medication to some and a placebo to others, but we don't know which one's which. And that's the way we can see whether there's really a genuine effect over and above placebo. And that's what we need to be focusing on to get the treatments right for long COVID.
I think that's very, very important. So I have complete sympathy for Harry and Zoe for trying out things. And of course we do. But Harry reminded us that the doctors have the do no harm principle. I think that should apply to patients as well. You know, of course, there are harmless things. Cetirizine, the antihistamine, is also over the counter in the UK. But he also mentioned other things like blood filtration. There isn't a long COVID particle that you can filter out of blood, and extracorporeal circulation comes with its own risks. So please be mindful to do no harm to yourself. What Tim suggested about diet, that's something very, very simple, has some evidence-based, and will definitely not do any harm. From personal experience, I should add, alcohol is really difficult. Anything more than 0.1, so half a small glass in a pub. You know, for many months that made us feel very, very rotten. But Claire's point is extremely important. I mean, as patients, please, when you go to these long COVID clinics, enter into all the trials you can, but don't try too much on your own. I think our own trial with cetirizine is an illustration. If you take it and you feel better, it might be because you've taken it, it might be because you're doing something, and it might be just sheer coincidence. And, you know, because we were double-blinded, we didn't know what we were taking, and there was no clear effect in an N of two people. But please everybody should spend energy in getting into trials. And of course, in a way, COVID Zoe is also a trial of symptoms and what happens over time.
Thanks, everyone. So moving on, I think the other trial that actually has been carried out at a huge level is vaccination. Did vaccination help? If you've got long COVID, did it help to prevent long COVID? And can you still contract it? These are often common questions. And can it be a treatment in itself?
So yes, actually, patient groups of long COVID SOS produced one of the first sort of pieces of data where they asked individuals how they felt after vaccination, and they found that more people got better than who didn't get better, who got worse. But there were some people whose symptoms got worse. But of course, we know that long COVID is a fluctuating condition, so it's really difficult to pin that down to being the vaccine. But overall, more people got better after the vaccine and felt that that was related to it. We've seen the same within the Zoe data. We're not sure whether or not that's because things get better over time. And we're trying to sort of really bash the data to try and work out whether we can answer that question. And I think at the moment, I'm unable to say whether a vaccine, if you've got long COVID, really makes a difference. But what I can say, Tim, which you've already alluded to, is that if you haven't had COVID so far and you get a vaccine, your risk of that, if you did then get COVID, your risk of getting long COVID is dramatically reduced. And of course, your risk of getting infection in the first place is reduced because you're immune to the virus to start with. So we think that really one of the best preventative strategies is to make sure that you get double vaccinated. And it's important that you get that double vaccine because that's when we really see the effect on long COVID.
And there's a sort of related question here, which I think is some of our is pertinent to our latest data from the app. Is having had long COVID, does that prevent reinfection of COVID, and how much does it compare to having a vaccine? I guess is the sort of question.
Oh, Tim, well, we've been having good discussions about that recently, haven't we? Because we've been looking at the effect of vaccines plus previous infection and so on. And we can certainly see that they seem to have an additive effect. And there is a strong protective effect from previous infection. We know that. If I was somebody who hadn't been vaccinated yet and had had COVID in the past, I would still get my vaccine because I know that will strengthen my immunity. So I don't think I wouldn't say that it's the safest thing to say, okay, I've had COVID in the past, I'm all right. I think having that extra protection from a vaccine is definitely key. I don't know if you'd agree with that, Tim.
Yeah, no, I think we're sort of seeing something like 64% protection if you had previous COVID, and that going up to over 90% if you then have a vaccine after it. So the best way if you've had long COVID recovered, the best way of making sure you don't get it again is not to rely on the natural infection, but to have the vaccination on top of it. I think that's the message that's coming loud and clear from our data. Got lots more questions. We're not going to be able to answer them all, unfortunately, but a question really about long COVID and its effect on the healthcare system. Rising health admission rates would put pressure on the system. And we've talked about hospital admissions, but often long COVID, most of them don't get admitted to hospital, do they? So I don't know whether either of you could have a brief comment on the state of the NHS dealing with long COVID and admissions at the moment.
I think it's very important to keep in mind that the NHS is in a fragile state after essentially 2 years of emergency, state of emergency, and so it is important to not get COVID in the first place. Both of you have emphasized the need for vaccines. As I said at the beginning, I didn't predict I would get it badly. It is unpredictable whether you get it badly. So do make sure you don't get it, even if you've had it
Claire, final word?
Yes, I think that what's important is that people go and seek help and seek care, and the structure at the moment should be able to, in a sense, filter out whether there's something that needs a specific treatment, or whether it can be supported and people can be supported by rehabilitation strategies.
Yeah, but what's clear is that with the high rates of COVID at the moment, it is hard for long COVID sufferers to get the full support they need, as it is with 13 million people with other chronic diseases waiting to start different treatments. And I think that's one of the things, people say, oh, well, we've had Freedom Day, it's all fine now. But with, our estimates of over 60,000 people a day and over 900 people a day getting long COVID, that's just adding to this list of problems for the NHS. So I, for one, would prefer we had more vaccinations, and we're dropping down that league table, and that's why we're doing so badly compared to the rest of Europe. But anyway, because of these problems, we are asking your permission to include wider healthcare reporting on the Zoe app, and hundreds of thousands you have already converted to that, as we look more broadly outside COVID at some of these other conditions that have been neglected so badly after the last 18 months. So if you haven't done so already, do go on the app and click to widen the health questions. I want to thank Claire and Alexander for joining me today. Thanks to everyone who joined us. Fantastic questions, and those particularly who log with us every day. The Zoe COVID study is an essential tool used by government to help track the pandemic. Do keep logging the app and sharing with friends and family. We'll be sharing useful links and information to help anyone who wants to know more about things we've talked about today. So keep an eye out for those. Please subscribe to the Zoe channel on YouTube and Facebook for all updates. And thanks everyone again for listening, and thanks for your incredible support.